Hi, good afternoon, everyone. I just want to say thank you very much for the invitation. This has been a fantastic meeting. So here we go with innovation in orthopedics. Here are my disclosures that can be found in the program as well. And here's our outline. We're going to learn a bit about trauma-induced coagulopathy. What does that mean? Some viscoelastic assays. What on earth does that mean? And maybe some really innovative therapeutic strategies that are either in place or coming down the pipeline. So trauma-induced coagulopathy is really due to an imbalance in our pro and anticoagulant factors. And this is really important because it results in this spectrum of disrupted clotting. So when you initially undergo a trauma, there's a high bleeding risk. But then very, very quickly, this transitions to a hypercoagulable state and increased risk for venous thromboembolism, or VTE. This is important to orthopedic traumatologists because hemorrhage is still the leading cause of potentially preventable death in trauma. And then on the flip side, if thankfully our patients survive, then venous thromboembolism remains the leading cause of morbidity and mortality afterwards. And so we're quite limited in some of our technology at the moment. Our conventional coagulation tests, though they're very good at giving us little pieces to the puzzle, we have to take all of these different biomarkers and blood tests and put them together to really understand the overall trauma-induced coagulopathy spectrum. And so this is where new technologies such as viscoelastic assay testing, such as TAG, or thromboelastography, or ROTEM, are really good measures of whole blood analysis, so there's some advantages to that. The technology is now advanced so that it's point of care. The size of a TEG machine now is actually the size of a couple of Kleenex boxes. And it really helps us to represent and understand what's going on in vivo in real time. And so the way that this information is conveyed is both numerically and graphically, and it allows a comprehensive analysis of the clotting cascade and the patient's trauma-induced coagulopathy fingerprint, all the way from clotting to breaking down clot or fibrinolysis. So it begins with measures such as the R time or reaction time, ACT or activated clotting time, moves on to clot propagation, so how much patients are forming clot as measured by the K time or kinetic time and alpha angle, and then how strong the clot is that the patient is really forming, and that's measured by maximal amplitude, and we'll hear quite a bit about that parameter. And then lastly, our ability to actually break down clot or fibrinolysis, and that's measured by LY30. So you can see we get this overall gestalt of what's happening with the patient in real time throughout the whole clotting process. So where this has great innovation opportunities is both on the therapeutic side for bleeding, but also, I believe, for clotting. And so resuscitation now, it's standard of care in a number of level 1 trauma centers to use patient-specific resuscitation based on viscoelastic assays. There is a whole host of support for the cost-effectiveness analysis for using viscoelastic assays, but also in saving less plasma, platelet transfusions, and actually improving overall survival of patients using a precision medicine approach as opposed to more population-based approaches like massive transfusion. And so we can also use this technology to look at underlying pathophysiology. So for example, if patients are not able to break down clot, they have disrupted fibrinolysis, that can really be an indicator for something like tranexamic acid, for example. So why wouldn't we apply this technology that's really having a lot of success in saving lives from a resuscitation point of view to the other side of the spectrum in pathologic clotting or hypercoagulability? This remains a really important factor. As you can see this statistic here, every 6 minutes in America, somebody dies of a blood clot. And so actually an orthopedic trauma injury we know is a very strong independent predictor of VTE risk. So that's pulmonary embolism and DVT. And this is despite our current thromboprophylaxis measures. One of the limitations, I think, in what we have to go on at the moment is we really lack consensus in our guidelines on the type of agent that might be best, the duration, is it based on the injury? We will talk about risk stratification tools, but our guidelines or population-based recommendations don't take into consideration things like age or sex or injury pattern. And so there's a lot of opportunity, I think, for innovation in this area. Here's a perfect example. On the one hand, you have a 32-year-old male, isolated ankle fracture, So let's use a risk assessment measure, such as the Caprini score. On the other side, you have a 72-year-old female, also an isolated ankle injury. And their Caprini scores, though very similar, they represent exactly the same risk. So we don't have the sensitivity in these parameters for surgical patients to be able to use a lot of our risk assessment models to actually guide thromboprophylaxis. So this is where more of a precision approach or actually using technologies like viscoelastic assays may provide some benefit. So we've previously used TAG analysis to show that parameter maximal amplitude, or the strength of a clot formation, can be used to identify patients at increased risk for VTE events. We've established a threshold of 65 millimeters or greater is really associated with increased risk of 4-fold or greater, depending on the injury population. We've additionally used this technology to actually show that patients are at risk after a hip fracture much longer than our thromboprophylaxis guidelines currently recommend. So in this pilot study, we followed patients out to 6 weeks, and over 50% of those patients were still hypercoagulable based on that threshold at 6 weeks, when they've long since stopped their thromboprophylaxis. And this really is in keeping with some of our big studies, such as the Health and Faith trial, where almost 50% of VTE events in this group occurred 6 weeks or later. So we now know that we can use this technology over time to look at duration of increased risk, but how about a biomarker that might help us identify who's at highest risk? This is some exciting data that we presented just recently at the OTA, where we're looking at one of the parameters, activated clotting time. And as you can see here on postoperative day 1, those who went on to have a VTE event had significantly different values compared to those who didn't. So this really lends itself to further exploration of that early parameter that maybe immediately after hip fracture and hip fracture surgery, we might be able to identify those that are at highest risk based on their physiology. So lastly, I want to talk about aspirin a little bit, because this is definitely gaining a lot of traction in some big, very well done randomized controlled trials. So thromboelastography also has the ability to use a technology called platelet mapping, where we can stimulate different platelet activation pathways to look at the effect on blood clotting. The reason this is important is we can actually measure whether aspirin, for example, is effective. This is some pilot data, 101 patients, where 18% of them were receiving aspirin postoperatively. And what I have here is a tracing that has the overall group that was not receiving aspirin, and the shaded area is platelet hyperactivity, so a bit of increased risk for very sticky platelet activation. Those who actually received antiplatelets, in this case aspirin, had a significantly lower maximal amplitude. So we're actually able to measure reducing that possible risk. And interesting, as soon as it stopped, we certainly see a very big rebound in that hypercoagulable state that is very platelet mediated. So I think there's some really cool opportunity here. So to summarize here, we've been able to show that hypercoagulability and increased risk for VTE in hip fracture patients in particular, but some of our other populations also, it's more prolonged than maybe we initially have thought and are prophylaxing our patients for. Platelet mapping is a great innovation that will allow us to measure novel therapeutic targets such as antiplatelets. And perhaps a precision medicine approach has some real benefits that we need to consider, because everybody has these devices in their hand, and so if there could be a personalized biomarker that could add to that risk stratification, we certainly might be able to help our patients. Thank you very much.